yesterday and leading our academic session. And we thank you again for what I know is going to be an amazing talk this morning. We're going to move things along and get them started because Dr. Cotton's also got a flight to catch at 11 in the morning, and I definitely want to get him to the airport on time. So as you're coming into the room, feel free to come on, grab a seat, and we're going to get started. So as you know, yesterday we had our academic research sessions. We're going to present our awards. Before we get to the research awards, in the tradition of the trauma program going back many years now, we have our Trauma Program Award of Merit. And it's an award that we're very proud of that highlights excellent work that's being done both in the hospital and in the community by certain members and teams that are taking care of our trauma patients. And this year we have a very special group of people that we want to highlight and recognize for some tremendous work that was performed in the community. This is something I know that's near and dear to Dr. Deckelbaum's heart. He's currently overseas now visiting a sick family member, but he's joining us via Zoom, and I'm going to turn it over to him to present this year's Trauma Award of Merit. So Dan, I believe you're there alive and well in cyberspace.
Yeah, thank you very much. Thank you, Jeremy, and thank you, Dr. Cotton, and everybody present for this year's Robertson Day. And I apologize that I could not be there. I did actually want to present this award. It really is something, as Jeremy said, that's dear to my heart. I'm going to do it in English and French so that everybody understands. Le prix de mérite en traumatologie est décerné chaque année à une ou plusieurs personnes qui ont consacré leur carrière à soutenir leur communauté dans la prévention ou la réponse à un événement traumatisant ou à une blessure. En tant que communauté et parfois même prestataire de soins, nous entendons souvent parler de ce que font ces personnes, mais nous ne comprenons pas vraiment les subtilités et les sacrifices de leur travail. Dr. Cotton, this is for you. The Trauma Award of Merit, because I'm sure you understood every word. The Trauma Award of Merit is given each year to a person or persons that have dedicated their career to supporting their community in either preventing or responding to a traumatic event or injury. As a community, and sometimes even as caregivers, we often hear about what such individuals do, but don't truly understand the intricacies and sacrifices of their work. Le 16 mars 2023, je me suis réveillé avec ma famille avec une odeur de fumée. Alors que nous ouvrions nos rideaux, nous avons vu un incendie flamboyant qui a été complètement enflammé le bâtiment devant nous. Rapidement, il y avait plus de 120 pompiers et des dizaines de camions de pompiers pour combattre cet incendie qui a mis des heures à être maîtrisé. Être témoin de leur courage en grippant les échelles dans le fumée et les flammes était une source d'inspiration. Bien que de nombreuses personnes aient été sauvées, malheureusement, 7 personnes sont mortes dans cet incendie. On March 16th, I woke up with my family to the smell of smoke. It was about 5:30, 6 in the morning, something like that. As we opened our curtains, we saw a blazing fire that completely engulfed the building in front of us in flames. Very quickly, within minutes, there were 120 firefighters with tens of fire trucks combating this fire, which took hours and hours and hours to control. Witnessing their bravery and climbing the ladders into the smoke and flames was inspiring. While many were saved, sadly, 7 people died in this fire. Ce qui rend ce prix spécial cette année, c'est que dans ce cas, les lauréats consacrent non seulement leur vie à sauver celle des autres, mais ils sacrifient également leur propre vie dans leur travail. Nous dormons bien la nuit, sachant qu'il y a des gens comme vous qui sont là pour nous protéger. Pour cela, nous sommes tous incroyablement reconnaissants. What makes this award special this year, and especially meaningful for me, is that this year the awardees not only dedicate their lives to saving those of others, but they also sacrifice their own lives in their work. We sleep well at night, knowing that there are people like you that are there to protect us. For that, we are incredibly grateful. So with that, I hand it back to you, Jeremy, to hand over the award.
Thank you very much, Dan. So for this year, for those of you who didn't catch with the fire and the ladders, we're recognizing the hard work from the fire department here in Montreal that responded to a 5-alarm fire in Old Montreal last year, as Dan had mentioned. And it's a tremendous amount of work that highlights the dedication, the commitment to excellence, to bravery that's emblematic of what we do every day in emergency surgical care and trauma care, that's represented not only by the surgeons, the nurses, the respiratory therapists, the pharmacists, the PABs, every member within the hospital. If we don't have hardworking community members such as the fire department, who's represented here today, to bring those patients to the hospital, there's little that we can do. And it's very important to highlight all of that tremendous amount of work that's done in the field. And for that, we wanted to recognize all of you today. We have 3 representatives from the Fire Department of Montreal that are here today. We're going to invite them up to come to the podium and present this year's Trauma Award of Merit, which I have here. And we'll take some photos. So to the Service de sécurité incendie de Montréal, on vous remet le prix de mérite, le programme de traumatologie ici au le centre de traumatologie David S. Mulder à l'hôpital général de Montréal. Félicitations et merci pour tous les travaux que vous faites pour nous garder en sécurité chaque jour et chaque nuit. So a big round of applause for everyone here that's in person. Clap along in cyberspace on Zoom, and please come on up. And I'll ask Dr. Khwaja and Dr. Patney to join us up here, please. Fantastic, and thank you. And then quite quickly, before we move on to some other introductions and to Dr. Cotton's comments today and talk this morning, again, thank you for the 35 participants that are online, and it's nice to see so many faces coming in to be here in person. A big thank you to all of the OR nurses that are coming in. It means a lot to me. Thank you guys for being here. So research awards for yesterday, we have 3 fantastic prizes. We have a special award of recognition, as well as our top award for basic science and for clinical research. And it's my absolute pleasure to get to those, which I'm going to pull off the table. So first, our runner-up, which is, just as important as the top prizes and the second prizes, but a special award of recognition that will be coming in to Tarek Playlat for the development of a novel inorganic polyphosphate releasing thermoresponsive hydrogel to improve fracture healing outcomes. Congratulations. Part 2 was riveting. Part 1 set a good foundation. Congratulations. Yeah. In our basic science, which is always odd when we say basic science, so primary translational research, fundamental sciences, much better than saying basic. This award goes to the presentation on polytrauma and spinal cord injury, a novel mouse model for chronic pain research. I butchered the name yesterday. It'll come again as well today, but Gopurkrishnam Unithuyam Radhakrishnam Unithiyam. Congratulations. And our top clinical research prize this year goes to Dr. Tiffany Parody for the impact of closure techniques on hernia development, trauma laparotomy patients, negative pressure wound therapy versus dynamic fascial traction. And we'll take one quick picture with all the award winners and Dr. Cotton, Dr. Quadja, and myself. We'll just go here in front of the table. Now that we have the formalities and the picture taking out of the way, I'm going to turn things over to Dr. Quadja, our medical director of the trauma program. And again, thank you all for being here.
Thank you, everybody. First of all, I wanted to take a few minutes to thank everyone who came yesterday and here today as well. You know, these past couple of days, it's been a very special, I think, past 2 days. The trauma visiting professorship is an opportunity for us to celebrate a lot of the tremendous work that we all do. So it's not just the trauma team, the trauma surgeons, it's the nurses in the OR, it's the Department of Orthopedics, it's the plastic surgeons, it's the neurosurgeons, it's blood bank. It's all of our hard workers at the Montreal General and at the MUHC who do a tremendous work to take care of our trauma patients. And you know, the performance is tremendous. You know, we're probably, you know, the best trauma center within Quebec and probably within Canada. So we should all be very proud of that. And that's really thanks to all of you. So I wanted to just say thank you to all of you for doing the great work that you guys do every day. I also want to thank a couple of people who did a lot of work in organizing this conference. First, Nancy Branco is probably one of the hardest workers I know. She did a great job organizing all of this. The trauma office also did a lot of work to make sure that everything was organized, all the the minute details of yesterday and today. So thank you very much. I also would like to thank Dan Deckelbaum, who in the past years has been sort of organizing this trauma day. And of course, Dr. Jeremy Grushka, who actually was not only our MC for the last 2 days, but has really put in a lot of work and did a tremendous effort in getting this day organized. Thanks a lot. So for all of you who may not have read the brochure, but this trauma visiting professorship is in honor of Dr. Rocke Robertson. Just a couple of words on him. He was our surgeon in chief in 1959 at the Montreal General Hospital. He was a leader in trauma care and surgical infections, and he was an international leader in surgical care. He eventually became the principal of McGill University, and he was the one who built or started the construction of the McIntyre Medical Building. So his impact not only to the Montreal General Hospital but to McGill University was immense. And so this trauma professorship, visiting professorship, was named in his honor. So without further ado, I'd like to introduce a very special guest today before Dr. Cotton. And I'm sure all of you know her. It's Dr. Lucy Opatriny. Dr. Opatriny joined us here last year as our CEO and our president of the MUHC. She is a McGill grad, and all of you probably know that her leadership skills led her to becoming the DPS of one of our partner institutions. She then became the assistant deputy minister at the Ministry of Health, and she did a lot of great work there. And we're just thrilled to have her back home at the MUHC to lead us through some difficult times within our healthcare system. And so we're actually quite thrilled to have her even here today to maybe give a few words today to all of us. So thanks, Lucy. Would you like to come up and give a few words?
Good morning, bon matin à tous. Puis avant de commencer, j'aimerais aussi vous remercier pour le prix et pour tout le service que vous nous offrez aux citoyens de Montréal. Un immense merci. Good morning. It's a huge pleasure to be here this morning et d'adresser à vous. C'est bien de vous voir en grand nombre en personne. Je vais continuer en anglais parce que notre invité est des États-Unis, so we'll do it in English so that you understand and can follow. So it's really nice to be here. It's one of the few first new events in hybrid fashion at the new and updated Osler. So very nice that it is for this Trauma Day. So it's online we have, it started working again. We're up to 65 actually online, so quite a lot. So it's been more than 20 years that at the MUHC we've been privileged to hear from worldwide from experts in trauma. People have had an immense impact on surgical practice, clinical outcomes, healthcare policy, and education, just like Dr. Rocke Robertson, for which this annual visiting professorship is named. And I see that this year is no exception. Welcome, Dr. Cotton, and thank you for accepting our invitation to participate this year. Many thanks as well to our organizers for putting this event together. The MUHC has distinguished itself really on so many fronts when it comes to trauma, from clinical contributions to war efforts, disaster preparedness, production of educational videos, just treating obviously thousands of trauma cases per year. And the fact that our institution has the lowest adult mortality rates in Quebec is a testament really to the ongoing commitment to world-class trauma care and a multidisciplinary approach on strong partnerships and teamwork. And really, this is ultimately what has and creates that powerful vision. And to see in this room, actually, people from, Dr. Kozar mentioned that nursing. I'm gonna, where is nursing? All right. So to have everybody here is a testament to that as well. So really, patients are hugely benefiting from the work that you do all the time, and from pushing the boundaries with education and research. So there are just hundreds of students, residents, nurses and other hospital personnel that Dr. Kozar mentioned that are trained yearly, that together you make the trauma program what it is. These accomplishments are really very impressive and worthy of recognition and support. And I'm very proud of our trauma program at the MUHC. With the team ready, what I now understand is called the golden hour, to carry out appropriate life-saving medical and surgical intervention that really give our patients the highest chance of survival. And I want to close by saying that we've all been working for many years to bring helipad service to the MUHC as part of trauma, as well as other time-dependent conditions. And so I'm delighted that earlier this year, the Ministry of Health included this in its action plan, both with which I look forward to working with several key clinicians in terms of the construction at the Glen site and the preparing, and eventually also for the Gen site, because it's obviously something that's critical for the trauma program. So thank you again for everything that you do. And I saw the program today. I think it's going to be a very exciting and wonderful day. Thank you.
Thank you, Dr. Patroni. Jeremy, would you like to come up here and introduce Dr. Cotton? Thanks.
All right, well, good morning, everyone, and it's my pleasure to reintroduce Dr. Cotton to everyone here who wasn't able to participate yesterday. We'll go a little bit with the formalities that you can find in your brochure, but Dr. Cotton is currently the John B. Holmes Distinguished Professor in Clinical Sciences and Professor in the Department of Surgery at the McGovern Medical School in UT Houston, at the Red Duke Trauma Institute at Memorial Hermann Hospital. He's the Director of their Surgical Critical Care, Trauma Surgery, and Acute Care Surgery Fellowship. His clinical specialties are trauma surgery and surgical critical care, and his research focuses on identifying the best resuscitation strategies for hemorrhagic shock. All you need to do is have your finger on the pulse of any portion of trauma care around the world, and you know the giant that Dr. Cotton is. It's been such a tremendous honor and pleasure to have him here in person yesterday and today, to be doing case rounds with our residents, being part of Morning Report, leading the academic sessions. He's everything that I hope to be when I grow up and become a trauma surgeon. But no, and looking that in my, it's a decade now that I'm back on staff, and there's not a talk that goes by, there's not a round that go by, it's not a day that goes by where we're not quoting his work, or it's not coming up in any of the discussions. As I said yesterday, and it's as true yesterday as it is today, this is an ultimate fanboy moment for me. And I'm so thrilled to have Dr. Cotton here and to have him participate within our trauma program. We're truly very fortunate, and thank you so much for being here. His work as a clinician, as a researcher, as an educator is enormous, but the most powerful part of it is when you speak to any of his trainees, anyone who has been within his sphere, you know the quality of human being he is, the compassion that he shows to his patients, the sense of humor he has, the commitment to crossing the finish line and making sure that he brings everyone up with him to another level. And that's really the biggest thing that we can do from any type of team. With our firefighters that are here today, our residents, the nurses that are here, the docs that are here, the administrators, we all can do great with our own individual achievements, but we know we're far stronger when we work together and we bring everyone up and raise everyone around us. And that's what Dr. Cotton has done throughout his career. It's what he's done as a father of 6. It's what he's done as a leader and a mentor in trauma surgery, and we're thrilled to have him here. I could go on and on and on, but people are going to have to go to the OR at 8:30, and you really want to hear Dr. Cotton's talk rather than me. So I turn it over now to Dr. Bryan Cotton. Thank you again for being here, and this will be an outstanding talk.
Once again, too kind, but I appreciate that. So I'm sure most of you have seen Forrest Gump. This is going to be Forrest Gump Goes to Resuscitation. This is pretty much not necessarily all my work, but definitely my lens, my view of resuscitation and the changes that occurred with it. Clicker. Advance like that. So this is what fluid resuscitation used to look like. This is actually in the operating room at Vanderbilt, May of 2005. And I found it humorous just to take a picture of what it looked like. And I'm going to try to take you in the next 45, 50 minutes from this to this, and then finally to this. And that's whole blood in the middle there with plasmins and red cells on the side. I'm going to try to take you from this back to this, because we spent way too much time with this. And for the older surgeons in the audience, probably get PTSD when I bring this up. And then the younger ones are like, what the hell is that? It's your intestines that are gotten way too much fluid. Again, the young ones may be out there going, what were you thinking? What were you possibly thinking? We know how to resuscitate. It's 1-to-1. It's a balanced resuscitation. So again, not necessarily all my work, but definitely my work through my eyes and the literature from the last 20 years. And it all started with my residency, 1997-2002 at the University of Missouri, Hospital and Clinics, Columbia. And this is, again, where I first had my awakening to resuscitation and how bad or off it had gotten. This is what my patients look like. Many of the blunt trauma patients, they were definitely having to swell to get well, to quote that horrible phrase I brought up yesterday. There was a tornado that came through 1998. I was a second-year resident in the ICU, and it came through 16 injuries, no deaths. I underline the no deaths because the tornado didn't kill anyone, but I did. So multiple casualties arrived that day in November of 98. The attending and the chief resident were in the operating room. My ICU attending and my senior resident were in the OR, and I was alone in the ICU. 20-year-old female came in, severe traumatic brain injury, long bone fractures, pelvic fractures. I did what we did back then. I gave her a lot of fluids, then I gave her some more fluids, and then I put an A-line in. Then when she still wouldn't respond, I gave more fluids and then more fluids. I put a PA catheter in, and yes, I put a PA catheter in a 20-year-old, and that's what we did back then. And gave her more fluids, and then I gave her pressors, and then I gave her finally some blood. Of course, that was just red cells, it was nothing else. Over the next 10 hours, she received 18 liters of fluid from me and numerous blood products and escalating doses of pressors. And again, the younger people in the audience are like, what were you thinking? Many of the older surgeons in the audience were like, yeah, we've been there. However, I delayed my diagnosis of abdominal compartment syndrome. She finally goes to the OR, gets decompressed. Her TBI worsens, progresses to brain death and organ donation. So, like I said, a tornado didn't kill her, but I definitely assisted in doing so. Fast forward to my chief resident year, I'm over at the VA, and I fall onto this article from something called Eureka Alert. This is pre-internet, and definitely pre, PubMed or Twitter or things like that. And I had a search thing going for fluids on my search bar, and it would send me once a week a little email of articles that might be of interest. And I fell upon this one, and it was a very small randomized trial, but it blew me away when I looked at it. It was in GI surgery, and they were restricting the fluids of these patients peri-op. They weren't loading them up pre-op, minimizing the amount of fluids they had intra-op, and then post-op, kind of saline locked them post-op. And by doing so, they were able to improve the time to flatus, time to the first bowel movement, time to tolerating PO. They even did gastric emptying studies with nuclear medicine, gastric emptying studies, and showed resolution of both solid and liquid phase improved in those patients with fluid restriction. And so I started adopting that almost immediately as a chief resident, but too soon that I graduated and went to my fellowship. I went to the University of Pennsylvania Hospital and Children's Hospital of Philadelphia, where I spent the next 2 years, 2002, 2004. And again, we practiced a lot of the Maddox papers, people will call it, or actually first authors, Bickle, Maddox is a senior. But it was a paper out of Houston who are our partners actually next door at Baylor. I'm at UT. And they about 300 patients in each arm. And what they did is they randomized them to get no fluids, which was kind of that against the ATLS criteria and teachings for decades. They were going to give no fluids until they got to the operating room. No fluids in the field, no fluids in the ER, or trauma bay, and straight up to the OR. And then once they got to the OR, anesthesia could do whatever they wanted, no restrictions there. Or they got standard resuscitation, which is about 2 liters pre-hospital, maybe a little bit more in the ER, and then up to the OR. By the way, these are all penetrating torso trauma. So sick, hemorrhagic shock from gunshot wounds to the chest. And what they found is their blood pressure, yes, it was lower. Again, we're going to get to that later with permissive hypotension. And their coags were better on arrival if they got no fluid. And then again, you look at the amount of fluid they got, they still got a little bit of fluid, 92 before they got to the pretty much a saline lock and just a flush, and then about 300 in the ER. The other group got over 2 liters, which again is about standard at the time, even for penetrating. And what they ended up finding was this, is that they had improved survival. They had an absolute difference of 8% improvement in survival in the patients that had a delayed resuscitation versus those who did not and got a standard resuscitation. So we kind of adopted that. We used that. And this is us again in the operating room. That's kind of how we practiced, how we played in our patients. But again, overwhelmingly penetrating when I was at Penn. Then I went to my next venture down to Vanderbilt, 2004, 2009. It's shocking I lasted that long, but I'm going to show you why. So I went there to stomp out delirium. I hated taking care of confused old people in the ICU. I didn't want to take care of them. They clogged up my ICU. I wanted to operate, right? And I went there to work with Wes Elio, absolute pioneer in delirium research. I had zero interest in resuscitation or bleeding, other than my kind of side gig of trying to figure out how I could take care of these patients better. But things changed. I heard you got to swell to get well. I heard a resident call out, blow them up like the Michelin Man. These were real comments made, and this was the way that we thought we needed to take care of these patients, especially because I was told, well, that's penetrating. It's different. This is blunt trauma, Bryan. You have to swell to get well. This is what our resuscitations look like. This is what our bowel look like. And this is me, young me, getting frustrated because one of the things I hate more than all these extra fluids is TPN, because we've made the bowel so edematous they can't tolerate feeds. So again, you're probably saying, what were you guys thinking? What was going through your minds? Let me take you back a little bit. So again, you saw some of these slides yesterday. Shire's work initially comes in, says we need this extra fluid. We've got this third space volume from trauma and from injury and from surgery, and we need that a little bit extra fluid, the third space, if you will. And then again, on the other side, Franny Moore says, no, 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 we don't need that extra fluid. We're actually retaining it. You need to back off a little bit. They make their plea for moderation like we talked about yesterday. The plea for moderation is absolutely ignored by the public. We go to Vietnam, we have the Da Nang lung, we have this acceleration of fluids. Then we have, when I'm rocking this amazing outfit back in the 70s, we have this stuff coming out in the early 80s from Shoemaker and others talking about supernormal resuscitation, which again, I've always thought was this Darwinian challenge that if you can tolerate all this fluid we're giving you, you deserve to live. But the supernormal resuscitation got out of hand and it became a standard of care where we were truly trying to drive them up to supernormal oxygen deliveries. About the same time, what happens? Harlan Stone, like we talked about early yesterday, comes in with damage control or abbreviated laparotomy. Let's leave them open for a little bit. Let's correct this coagulopathy, which again, hadn't really been described, at least as robustly, before that. And if you go back to that actual Harlan Stone paper, he's talking about doing it on table briefly, the kind of the ultimate let anesthesia catch up moment where you're in there, you pack them off and then you let them catch up, correct their coags, correct their acidosis, and correct their hypothermia. And again, a pretty small number of patients that we had. However, they did absolutely have a better survival in those that were packed open versus those that they tried to just finish and close. Absolutely improved versus those that were, again, had a lethal coagulopathy. Then again, that supernormal resuscitation was a huge injury to this. But all these things, all these ships are passing in the same part in the middle of the night. And we didn't really figure it out and see it happening in front of us. But all these things were kind of coalescing at once. And this supernormal resuscitation was one of those problems. We stopped looking at them. Again, we talked about yesterday, heart rate, blood pressure, and urine output. We started to ignore things that were in there. And then we started focusing on the other things we talked about yesterday, chasing lactate, chasing base excess, which again are really, really awesome. And we talked about this paper yesterday. And yes, that's real natural hair I'm rocking there. These are my college years. And this is what the paper we talked about from Scalia yesterday. Again, the Scalia paper said time to clearing lactate is important, but we didn't interpret it like that. Even though, again, we had people that never cleared their lactate that survived, and people that cleared it that obviously died. What we heard is we have to clear this lactate now as soon as possible. And so in chasing it so hard, so fast, we were overwhelming these patients with so much fluid. And this is what they look like. Again, damage cure just comes in from Penn, from Rotundo and those guys. And then you start seeing abdominal compartment syndrome. Now we're leaving them open because we have to, not because we were trying to save their life and bring them back the next day to fix everything. We were actually unable to start closing these patients. I was invited with my personality and my different thinking when I was at Vanderbilt to go and present grand rounds 6 months in. This is my slides from that December 2004 talk. And this is literally obviously the labels at the bottom are different, but this is actually, I cut and pasted it into the slide deck from my original talk. And this is one of the things I presented when I was there at Vanderbilt. I delivered this to a full audience at Vanderbilt in December of 2004. And during the talk, all 4 senior faculty got up and walked out of the talk at different points. And they weren't all paged out. They didn't have something pressing to do. This was their silent little protest and walking out because they didn't appreciate what I was saying about fluids. However, one audience member stood up and led the applause at the end, and one actually took me under his wing. One was Dan Beecham, and the other was Najia Boomerad. Dr. Boomerad came to me and wanted me to continue this work. And I'm like, they don't really like it. They're not a fan of this. And they're like, no, we should do something with this. So he came to me, we wrote an article, he and I, about pretty much a review of my talk that I had just given. And he said at the end, well, who should we put on this? And, what should we do? from your division? I go, well, they don't believe in it. They are absolutely against what I'm talking about. And he's like, well, you should do this as an olive branch, Brian. Let's put someone on there. So we ended up putting my boss on there, John Morris. And he's like, anyone else you want to put on? And of course, immature, angry Brian Cotton at the time says, well, who do they hate more than me? They hate Jeff Guy. I want to put Jeff Guy on. So I put Jeff Guy on, who was actually used to have a podcast, and he covered all kinds of topics. But Jeff Guy, fantastic guy, is now one of the CMOs of some of the hospitals down in Tennessee. But the rest is history from there. He told me my career was going to change at that point. I'm like, you're crazy, Dr. Memrod, but I'll do this article for Shock, and then you'll get off my back, and I can continue to just try to keep my job here and keep taking care of patients. But once this came out, it really did. I started getting invitations to meetings, think tanks and stuff like that. John Holcomb and some military people came after me and started asking me about the article and some of the research. So it really did take off from there. About that same time, this paper is coming out from, again, we talked about this one yesterday, about the tenets of damaged stroke resuscitation of permissive hypotension, limiting crystalloid, and then again, giving a balanced resuscitation closer to whole blood. Bringing all those things together, the one thing I could do at Vanderbilt at the time was try to see if I could get as close to that as possible through a massive transfusion protocol. So I developed a massive transfusion protocol. Now, I brought it to my group in trauma. I was shot down twice. They told me it was wasteful. It was unnecessary. We know when we need blood, we can just call for it. It's fine. It's fine. And so I did what, again, Brian Cotton in 2004, 2005 would do. I secretly joined the transfusion committee and brought it to the transfusion committee. And so the transfusion committee thought it was a great idea. And so I developed a protocol, and I developed it pretty much in secret with a couple of other people. And again, you can see here at the time, it wasn't one-to-one. I was working with the blood banker who believed in better ratios and quicker delivery of those ratios, but not necessarily one-to-one. You can see here, it was kind of a 3-to-2 ratio of products, although the platelets were a little more balanced. And these are the people that helped me deliver it. I was talking to some of the guests last night at dinner. This was on the far side. Here is Oliver Gunter, who's on faculty now at Vanderbilt. The one in the middle is Brigham A. I have an affinity for bringing on med students, giving them multiple publications, and then they end up going into ortho. So, and Brigham is the first of many. And this other one is the young faculty that was the head of the blood bank at the time and didn't want to be in charge of the blood bank. She actually was a stem cell researcher, pathologist, but she was the youngest in her department. And they're like, here, you're going to run the blood bank, the most ungratifying position you possibly can. And so she and I hit it off well. We developed all these papers. I went there to do delirium. She went there to do stem cell cancer research. However, now she's Pompey Young, who's head of the American Red Cross. So she definitely has gone and continued along that vein. We did this paper, damaged stroke hematology, before we'd solved the damaged stroke resuscitation concept or name. And we're trying to focus on getting products to the bedside quicker through this automatic master transfusion algorithm we showed. And what we found was a reduction in mortality in these patients, as well as a reduction in blood product use, which, if you think about it, is a true win here, because most people that die aren't going to use a lot of blood. They're not going to be around long enough to do it. So we actually saved people's lives and saved blood products. We were actually able to get on top of it and get hemostasis quicker. So we didn't have that, and had a huge number of unexpected survivors. Continuing the Forrest Gump theme here in the trip through resuscitation, this actually was also a paper presented at the exact same time WSD from Juan Duchesne's group in Tulane, looking at it and showing pretty much what we were looking at, which is our resuscitation and our ratios. They actually focused not just on massive resuscitation, but kind of a less than massive resuscitation, and showing those that got less than 10 units still benefited from a higher ratio. This is Terrence O'Keefe. He was at Southwestern in Parkland at the time, did a very similar process, showing he was able to reduce, by implementing a protocol, his red cell use, plasma use, and platelet use. We then found and kind of turned the corner, and I had a lot of pushback from some of my faculty about, all right, fine, maybe it is a good thing and getting some lives saved. However, you've got to be boxing their kidneys. You've got to be causing some other problems. It can't just be, all good. Well, we looked at that. We looked at all those things, and we did not see it change in renal replacement. Exact same rate, pre and post. We saw less sepsis. We saw less pneumonia. We saw less open abdomen. So it was a win in a lot of directions. Now you start to get into those other, the first of those three tenets, those higher ratios, balanced resuscitation. This is John Holcomb and Charlie Wade, and they really kind of put together stuff coming out of the military, although this is a civilian study looking specifically at this. And what they looked at was that high ratio plasma and platelets versus high of just one of them and a low of the other versus low and low. And you can see here the high had the absolute best survival. And if you really hone in, you can see where it's really happening, which is those first few hours. We're not saving them in 24, we're saving them in 2 to 3 hours, or we're not from hemorrhagic shock. Again, getting back to the argument that this is all about penetrating and blunt, you get a swell to get well. Well, this is Jason Sperry at Pittsburgh. He looked specifically at this in an exclusive multi-center blunt trauma data set and showed pretty much exactly what we showed. Higher ratios are better, even for blunt trauma patients. So less crystalloid, higher ratios of product. This then culminated in us doing a randomized trial of ratios of 1:1:1 versus 1:1:2. For the proper study, just shy of 700 patients. And I will tell you, things changed over time. The rate that we were predicting in the 1:1:2 group was about a 30% mortality. That was lower than predicted because, again, things got better over time as those fluids got down. And so the ratios didn't show as much of a difference. However, I will say that if you were bleeding to death, not a bad head that happened to be bleeding, but a bleeding to death without that head injury, you actually had an improved survival with a significant p-value, and you had quicker time to hemostasis. So the bleeding to death patients were improved in the study with 1:1:1 versus 1:1:2. The combos with the head injury were not. However, regardless of head injury or not, I know which curve I want to be in if I'm looking at this Kaplan-Meier, and that's going to be the 1:1 group. Next is minimizing crystalloid, which is the second of the three tenets. And we know the large volume resuscitation is a bad thing. We know it hits the heart, screws up the cardiac contractility, messes up the cardiac with cardiac disturbances. We know it hurts the lungs on multiple levels. We know it causes an ileus and causes bowel dysfunction. And we know it actually hurts kidneys. You may think that fluids help kidneys, and they can in certain situations, but too much fluid can actually, and we've shown at our center, can cause almost a compartment syndrome within that capsule and actually lead to worse AKI. We know that fluids in the ER and early on are absolutely the causative factor for abdominal compartment syndrome, and plenty of people have shown that. We've actually shown, and this is Ken Gianaba, and his study looking at it, showing that giving fluids and how much fluids we give in those first couple of days actually determines or impacts the leak rates of our anastomoses. And he was focused specifically here on colon anastomoses, and that was a big driver of getting it. And again, we're not talking about a huge amount. If you think about how much fluid you may even give these, like right now in 2024, giving 10 liters in 72 hours is not a huge amount. I think it's a huge amount, but it's still probably not abnormal in most places. But that is a huge trigger for getting into a leak in your colon anastomoses. And as far as IV fluid administration goes, this is my class from Penn, and we were all inducted Barrett College of Surgeons. I worked with Elliot Hout on this one and looking at pre-hospital IV fluids. Okay, real quick question. Who do you think benefited in this analysis from getting pre-hospital IV fluids? Any certain groups you think might have benefited? That's right, no one. That's good. All right, so no one benefited. The only people that weren't harmed were those with an ISS less than 9, which means you weren't really injured, and that if you had a normal blood pressure. Those people weren't harmed. You can see it crossing. Everyone else was on the other onto the right of the slide, and they absolutely had harm from it. Wad Duchesne, once again, talking about restrictive fluid resuscitation and how by restricting fluids in his protocol, in addition to his master transfusion protocol process, the restriction of fluids actually improved survival, or was associated with improved survival in this population by almost over 30%. Which brings us to permissive hypotension. A little bit harder kind of to gauge, a little bit harder to understand. This from our friends next door, Maddox, and our other colleagues at Baylor, looking at hypotensive resuscitation. So they took their normal process we talked about earlier and then added to that when they hit the ice or hit the OR, randomizing them to a MAP of 50 or a MAP of 65. And what they found is that by lowering their MAP goals, they were able to reduce the amount of red cells transfused, reduce the amount of plasma, and reduce the EBL in these patients. This one from the Rocke Consortium, multi-center trial, showing that giving minimal crystalloid with if you have no radial pulse or a systolic less than 70, or giving standard resuscitation to keep a systolic greater than 110, and showing a reduction in mortality among blunt trauma patients in this study, significant reduction by using restrictive fluid policy. And then bringing all three of those things together and layering them all in, looking at it and showing damage curve resuscitation being implemented at our center was able to increase survival 2.5-fold in addition, and controlling for all those coagulopathy and hypotension and shock and other variables. And then from there, though, you're not just done. You got to mature the concept. You got to keep making it, take it better. You don't stop with this research. It's one of the take homes here. And this is one of our performance improvement projects we looking at it, and we tried to figure out all the factors and identifiers that we could fix. And there are a lot of been there about ratios and make sure we gave the right ratios and things like that. However, one of the biggest things, the modifiable things, was activating it early. If we activated it in our trauma bay versus in our OR just a few minutes later upstairs, we had a reduction in our improvement in our survival almost 3-fold. So activating in the ER versus activating the OR, 3-fold difference in survival. And so we tried to figure out how this early recognition could be taught. We talked about the shame impact yesterday and how to use shame as a motivating factor. But what we did and to try to do is we came up with a score. And actually, this is the ABC score. Tim Nunez was one of the authors. Leslie Dossett, Will Dutton, we talked about them yesterday. We're resident and fellow at the time. And we approached it, we were looking for something simple, and the Tash score was not it. And the McLaughlin score was not it. So we wanted something very simple. We got down, me, myself, and Bill Reardon, one other person, Tim Nunez, sat down. We go, how can we come up with something simple? And we all threw out pretty much the same variables, these 4 variables: penetrating, yes, no; hypotension, yes, no; tachycardia, yes, no; positive fast, yes, no. Very simple. And we had Leslie Dossett, who was the resident in doing her MPH at the time, and run our stats. And she said, this performs just as well as the others. This is pretty impressive for such a simple score, not logarithmic weighted and all complex like the ones I just showed you. What should we call it? This is fantastic. And my nickname was ABC, or Angry Bryan Cotton. And she's like, well, I'll call it the ABC score until you come up with something better. And I'm like, we got to come up with something different than ABC. Let's figure something out. So we came up, we tortured it. There weren't, as you can see here, there's too many consonants, not enough vowels. I wanted something that stood for something easy to remember, like an APGAR or, NASA. Like I wanted every letter to mean something. I couldn't really come up with it. So I kind of abandoned it and was like, you know what, I'm just going to call it the Civilian Massive Transfusion Score. We're in Nashville at Vanderbilt, CMT, Country Music Television. It'd be a nice little hitch that we can do. So I went to present it at my faculty meeting. And again, by that time, I've already been sent to the VA, and I'm only allowed nights, weekends, and holidays to come over and do trauma at this time. But I came back for our triage meeting for abstract submission, and I go to present this, and it's well received, surprisingly, by my faculty. And they go like, oh, this is fantastic. What are you going to call this? And I said, well, we've been calling it the ABC score, and then I'm getting ready to tell them the delivery of the CMT score. And they're like, oh my God, you can't call it that. You've got to call it the Vanderbilt score. Yes, the Vanderbilt score. And I'm like, ABC it is. So again, I'm not trying to condone or teach you guys pettiness, but it has played a large part of my career. But we lined up the ABC, McLaughlin, and Tash together, and they performed very, very similar. So then we validated that through a multi-center trial, looking at it from different trauma centers across the U.S. And it, again, performing in each of those centers very similarly. We then said, all right, well, maybe it doesn't work in a rural setting. So we went and looked at Mayo. That is Brian Kim was one of my former fellows. And that's Martin Zielinski, who was also at Mayo at the time, but now is next door at Baylor. They looked at it in a little more rural setting up in Mayo, and found that it absolutely performed well. Now, it over-triaged, which is fine. That's the key to trauma, right? Over-triage, don't under-triage. So the under-triage rate was less than 5%. The over-triage was about just under 50%. but I would argue you can always send the blood back. You can't get it quicker if you haven't already ordered. So the ABC performed well. The next step was working with Dr. Dave Myers, one of my partners, and really trying to bring this together. This is us at, let's see, Everclear, Cult, and Smashing Pumpkins. That's pretty much the only time we hang out outside of work is to go to a concert. But we brought this together in this concept to look at the time to delivery of that first cooler and the time of activation. And within the proper study, randomized trial, we had people with clipboards writing everything down minute to minute. It was a wonderful capture of data. And what they found was it took us 9 minutes from the time they hit the door till we made the phone call to call for a cooler across the 12 centers. It took us another 8 minutes to get that first cooler. However, every minute delay in getting the phone call or getting the cooler resulted in longer time to getting hemostasis and an increase in mortality. In fact, when we broke it down, every 60-second delay in getting the cooler to the bedside from the time you made that phone, every 60-second delay was associated with a 5% increase in your mortality within proper. So as controlling for everything else, it was just as powerful as the blood group. In other words, if you could get me 1 to 2 in a quicker than 1 to 1, I'll take 1 to 2 until I can get 1 to 1. So that was really the take home. Every 60-second delay, 5% increase in your mortality. So then we took to expanding this to the ED. This is Zaid Radwan, a med student, worked with me, did a bunch of stuff with me, got about 8 or 9 publications. What did he do? He went into ortho. So again, now my daughter is interested in ortho as a med student, so go figure. So ED, bringing it to the ED and having it available in the ED, like that cooler I showed you, just by doing that, we were able to obviously get plasma in quicker, but we were able to reduce 24-hour transfusions when we implemented this protocol and reduce our use of the master transfusion process. And then again, it was an independent predictor of mortality as well. So moving it there was a big thing. So then we move it to the pre-hospital setting. This is Josh Brown from Pittsburgh looking at this, showing that by bringing blood to the pre-hospital setting, both seeing transport as well as transfers by HEMS was able to improve survival by having the red cells at the time in the pre-hospital setting. Martin Zielinski, Brian Kim, obviously at Mayo, did the same thing, showing pre-hospital plasma use on their helicopters using kind of an ABC score plus some point of care tests, was able to guide their resuscitation and get improvements in survival. However, none of them really trumped this one, which is a randomized controlled trial, multi-center, the Pamper study. This is Jason Sperry's group that put it together from Pittsburgh, but again, it's multi-center, and they looked whether or not having plasma on your helicopters, whether or not you had red cells or not, having plasma on your helicopters, what kind of an impact that would make. And so patients could get either just saline, they could get just red cells, or they can get red cells and plasma, or just plasma. And what they found in the study looking at 30-day mortality was the plasma-only arm actually had a better outcome than the standard of care patients. In fact, plasma and red cells together had the best, followed by plasma, followed by red cells, followed by standard of care. So again, I've always said our patients aren't dying from anemia. They're not dying from an oxygen carrying capacity. They're dying from volume and coagulopathy. And so plasma being the winner was not a surprise. Plasma, why is it so amazing? It's got a lot of stuff going on. It's got fibrinogen in it. It's got a lot of other factors in it, clotting factors. It's also a tremendous acid-base buffer with a buffering capacity, tremendous amount. Traverso looked at this years ago and challenged acid-base challenges to different solutions that were out there. And the ones that had the best buffering capacity were plasma from a pig and plasma from a human. In addition to the acid base, it's got an incredible amount of oncotic pressure, and it also stabilizes the clot and vascular endothelium. It takes that damaged endothelial lining of our vessels that are all leaky and now in responding to shock, and restores them to a healthy glycocalyx and reboots, if you will, the coagulation inflammation system. So what's the next step then? Not surprisingly, I'm going to end with this, which is whole blood. Whole blood head-to-head is not the same as 1-to-1-to-1. Whole blood is much, much better. Whole blood, though, why did it even go away? Well, back in World War II, all the way through early Vietnam, it was the preferred product of choice. But we got really good at breaking up parts of these into components. And, you think about it, you don't take a car, steal the car, and sell the car. You take a car, chop it up, sell it for parts, make more money. That's not why the blood industry necessarily did that, but they knew they could serve more people that way. And it made sense. You give the anemic patient some red cells, the coagulopathic patient some plasma, the bone marrow patient some platelets. It really was a good public health move to do that. However, they never studied it to see if it was going to be comparable for patients that were in hemorrhagic shock. They only showed that they could do it. And so all of these studies that were done with whole blood were then misinterpreted, like we talked about yesterday, that said saline safe. They said saline was safe while you're waiting for whole blood. They said you don't need platelets and plasma, which is what ATLS embraced. And like you saw, I was just giving red cells to that patient that died early in my career, because that's what we were taught. You just need red cells. You don't need the plasma platelets. However, the study, going past the abstract, you see they said you don't need plasma and platelets in addition to whole blood transfusion. So again, we misread some stuff. We had a lot of stuff going on. We had these studies. Again, this is the actual study from Carico, talking about giving a liter or two over 45 minutes until whole blood was available. This is the count study until whole blood. If you're using whole blood, you don't need the other stuff. All those studies were done, but we didn't pay attention to it, and whole blood just disappears from the environment. So then finally, we rebooted the system, literally. This is Jason Brill, who did this work with me, and we actually were showing that whole blood made a difference, and whole blood was associated with improved survival. This both from a 30-day survival, and we use less product when we use whole blood. It's more hemostatic. So massive transfusion mortality rates, and I'll end here, were as high as 65%. That first study I showed you that we did, the damage control hematology, we were so excited. We reduced mortality from 65% down to 50%. We were high-fiving. What do you think the natural or the normal one right now is in the literature? If you look at the literature, we're down to about 18 to 20% in massive transfusion mortality. We've made tremendous drops. Went down to about 50% in 2007. Our Iraq and Afghanistan experience brought it down to about 30%. And again, now we're about 19, 20% in our mortality. Whole blood ratios matter with damage control resuscitation, whether it's whole blood or it's 1:1:1. Minimizing fluid matters, and allowing permissive hypotension until you can get control matters. It begins in the pre-hospital setting. Bring whatever you believe in. We talked about that earlier in the visit. If it's TXA, put it on your helicopters, put it on your rigs, put it in the pre-hospital setting. If it's whole blood, like what I believe in, it's on our helicopters. We've got it on some of our ground units. We're putting it as far forward, as close to the patient as possible. So whatever you believe in, put it as close to that patient's site of injury as possible. Ratios matter. 1:1:1 appears optimal unless you have whole blood, and early detection of people that are going to need a massive is absolutely optimal and required. Resuscitation has changed dramatically over the past decade and for the better. And we question a lot of things that didn't make sense, which is what I would encourage all the trainees out there and young faculty. If you see something that doesn't make sense or rubs you the wrong way, investigate it. Don't just make a lot of noise, but really look at it and investigate it and do it properly. And hopefully you can change the system and change the future. We also look to the past for a lot of these. You see a lot of old stuff I throw up there that was actually right that we thought was wrong and dismissed it without actually paying attention. And again, finally, read past the abstract. Read the actual paper before you decide you've made a judgment about a certain summary or conclusion in a paper. I just want to say, I want to end with this one. This was my dinner. I got in late on Tuesday, and this was what I had. I went to this place called Reuben's. It was right down from the hotel. I got a Reuben poutine, and of course a nice glass of whiskey to go to it, and it was absolutely fantastic. So I don't want to hear anything about you talking about healthcare. I don't want to hear any jabs at the U.S. about our healthcare system. I don't know how you guys do it here. I know you do have it. You got to pay a lot of taxes, but Americans may want free healthcare, but no, we really don't, because we still want to eat like crap. So let us eat like crap. Leave us alone. Keep your healthcare here. So all jokes aside, thank you so much for the invitation. I hope I've taught you something. Thank you. Look forward to any questions.
Thank you very much, Dr. Cotton, for a fantastic talk. That was wonderful. Turn it over to the crowd. If anyone has any questions, comments, please come down to the microphones. I think there also may be some online. Perfect. And anyone else out there in cyberspace, please put your comments or questions through the chat. Go ahead. There's the microphones just behind you.
Thank you so much. I know a lot of this is way over my head, but I was very curious as to whether or not you've measured the results in cities like San Antonio, where the fire department is delivering whole blood products. Have you seen any clinical outcomes? And
Yes, so San Antonio Fire's probably done it better than anyone. In Houston, we haven't gotten it onto our fire units yet. It's just it's a pretty daunting task in Houston. But hat tip to San Antonio, Don Jenkins and those guys and others that have knocked it out there. And they've shown absolutely changed their expected deaths to expected survivors. That's where they've measured it, is looking at, was this patient predicted to live or die? And if it was predicted to die and lived, they've seen with their whole blood program throughout San Antonio and the ground units an improvement in survival and unexpected survivors. So yes, that's been measured there. We haven't done it in Houston on our ground units yet because we've got a handful out in the community that have it, that have longer drives in, but HFD is usually 7 to 10 minutes out, and there's so many of them, we haven't been able to put whole blood there. I'm hoping when freeze-dried whole blood or freeze-dried plasma comes out as a product, we'll have it on all the Houston fire rigs, though. Thank you.
Thank you for a wonderful talk, Dr. Cotton. My question pertains more to whole blood and whether or not you guys are doing O positive or O negative. And I know majority of patients in trauma are male. However, that female population, especially at childbearing age, do you guys have a protocol in which if they do get O positive, how are they being followed up?
Right. That's fantastic. So because of supply and demand, I mean, 90% of Houston is RH positive. And that means our donor pool is mostly RH positive. RH negative is what we started with the first 8 months. When the demand for whole blood in the city went up and people started catching on or getting interested in it, the blood provider for our area said, can we go to RH positive? We can't keep up anymore. And we said, sure, let's go to RH positive. So now RH positive is given to all of our patients, regardless of male, female, or age. We had a period there where we weren't giving whole blood to women. We finally worked through that and got through it. And now we give RH positive whole blood to everyone. We have peds hematology is identified if a female under 18 is given whole blood and she is a RH negative female. If it's a over 18, it goes to maternal fetal medicine, high risk MFM, and we don't mandate they follow up, but we give them the paperwork and set them up, and MFM has agreed to follow them up. And we actually just recently did a paper in JACS specifically looking at that, about our multidisciplinary follow-up with that. But yes, it's a hot topic, but when you really get down to it, forming antibodies to RH when you're in profound hemorrhagic shock is probably not as high as you think. It's about 70 to 80% if I were to give you whole blood right now. But if I shoot you and you're in hemorrhagic shock, and now it's going to be closer to single digits, probably about 3%. Then you've got opportunities for ROGAM, you've got opportunities for plasma exchange, you've got other things you can do. And there's actually a good thing called Allo Hope, ALLO Hope website and they are all directed about this research and all directed about how to intervene with women that may be at risk.
We have here in the chat one question for you, Dr. Cotton. What is the volume in a unit of whole blood that you guys are using?
Yeah, it's about 500 to 550 is a unit of whole blood, about 500 to 550 mLs.
Mitch Bernstein's up there. Mitch, you got a question for us? Your hand is raised. You can unmute yourself and go ahead.
Jeremy, did you call on me?
I did. You have a hand that is up, unless you're trying to high five Cotton, which I'll be happy to as well.
I want to tell Dr. Cotton I'm the program director of Ortho, so I'm happy to help out your daughter. And we have good contacts in Houston. As you know, they have a very robust ortho trauma program. But my question was, and I was reading between the lines potentially, but how do you navigate the politics of these big institutions and you know, the inertia of change and maybe some pearls from some young ones like me?
Yeah, so I mean, you've got to find out, not to be too creepy with it, but you've got to get in with all the relevant parties. And one of the things I did at Vanderbilt was I realized the obstruction in my own group, but more importantly, I realized that they didn't really have the power to stop it. And where the power lied was with the blood bank. And I used to always make the joke that that I was closer to Pompey Young, the blood banker, than any other female on the planet besides my wife. And it really was a relationship, and we still have this relationship for 20 years later. Now that she's head of the American Red Cross, we have a great relationship. We were both, you know, grew up, if you will, as young faculty together, but I realized where I could make the difference. And so for me, it was joining the transfusion committee, getting involved with the blood bank, and changing it from there. You've got to join, you got to be at the table to really make those changes. If there's an obstruction you're seeing, and if it's within your group, not just within the institution, you've got to join those committees and or entities that are making those decisions that are obstructing you and the care that you want to deliver for your patients. So I think that's really the best thing is to do. Make it multidisciplinary, get some cheerleaders on your side, get some other physician champions on your side, which is what we did. I got an anesthesia champion. And then at the end of the day, you could even go the full device rep, drug rep route, which is what I started doing when I realized I wasn't getting through to some of the anesthesia faculty. I started bringing bagels and coffee to the anesthesia residents at their education conference and talking to them for about 5 minutes every month about the protocol. And they started implementing and using the 1-to-1-to-1 and the massive ratios rather than having to rely on the faculty that may or may not even have been in the room. So you got to go with what you've got, the people that are delivering the care or that are obstructing the care, and you've got to join a lot of those different committees that make the decisions and make things happen.
I know we're a couple of minutes away from the OR starting, so one other question that's here in the chat. So Dr. Cotton, what do you think about using artificial blood products in pre-hospital setting? Is there any benefit?
So the Northfield trial was the closest we got to it. I think once they reboot that, there's some interest in doing so. It's a HBOC or a hemoglobin oxygen carrier that's artificial. If that is rebooted and can show some benefit, I think that will be back into the pre-hospital setting. I think we're closer though to like freeze-dried products getting to the pre-hospital setting, long shelf life. I think that's probably closer than the artificial products, but at some point artificial products are going to be studied again. The Northfield trial failed because there was too much crossover between groups, and you know the medics in the field were like looking at this bright red product and this clear product, and they're like, yeah, I know they were randomized to the clear stuff, but we're going to give them the red stuff instead. And I understand it. They were doing what they felt was best for the patients, but it absolutely destroyed the trial. So hopefully a new trial will come out and we'll have be able to show some benefit to these artificial blood products. But in the interim, I think it's going to be freeze-dried plasma, freeze-dried whole blood, and things like that.
Thank you very much. And if there are no other questions in the room, I know everyone's going to be off to the OR. So I wanted to thank Dr. Cotton again for being here as our 28th annual visiting professor for the Rocke Robertson Award. We have some gifts for you that we wanted to bring out. A lovely biography of the life of Rocke Robertson, a few other McGill surgery tokens, other things that you also need to check into your bag because you won't be able to bring them across security. But I think one of the big things also, and as Dr. Cotton had mentioned, always read past the abstract, read the paper, find out the truth. And if you don't have the time to read the paper, then just bring the person who wrote the papers to your university to give you the whole story. We went that route. It was a fantastic 2 days to have you here. We got everything, you know, from the top of the mountain from the guy who wrote it. And it's been an absolute pleasure. Thank you again for coming on by. Oh, it's my pleasure. Thank you to everyone for being here. Enjoy the day. And I hope you all have good cases in the OR. Remember, if you start to bleed, call for the MTP when you have that. And remember why we have one. It's because of this guy here. Thanks, everybody.